Our malignant hyperthermia case is a 14-year-old male, 5 foot 7, 155 pounds, 70 kilograms. No known drug allergies. He's healthy. ASA is 1. It's been NPO for 12 hours. He is adopted, does not know his family history of malignant hyperthermia. He is scheduled for an appendectomy. All right. How you feeling?
Mm,
Okay. And then go to the Before we talk about malignant hyperthermia, let's talk about how a muscle really contracts. Let's go into the anatomy. As you can see here, 1 is the sarcolemma. Within it contains tubules. Tubules are like cellular cliffs, trafficked. And of course, 3, we have the sarcoplasmic reticulum, or we will refer to that as the SR. The sarcoplasmic reticulum, as you can see to the diagram on your right, holds most of the calcium. Calcium that's inside this sarcoplasmic reticulum is released to bind with ATP, actin and myosin filaments, and the muscle contracts. Once the muscle is contracted, the calcium is then recycled back through the Circa port. It's an ATPase pump that transports calcium back into the sarcoplasmic reticulum to store calcium so that it could be released on the next impulse to contract the muscle again. With malignant hyperthermia, there is a genetic defect in the ryanodine receptors. Here I had ryanodine 1 and 2, but the most common form of malignant hypothermia happens with the ryanodine 1 receptors. About 70% of the patients that do have malignant hyperthermia have a defect in ryanodine 1 receptors. Once a triggering agent such as succinylcholine or our halogenated inhaled anesthetics, desflurane, sevoflurane, isoflurane are still the most common ones. If the patient does not know they have malignant hyperthermia and they have a defect in the ryanodine receptors, what happens when the triggering agent interacts with the body? Again, calcium here is being released through the impulse, comes down through L-type channel receptors, and the ryanodine receptors will release its internal stores of calcium from the sarcoplasmic reticulum. With the defect from the triggering agents, the sarcoplasmic reticulum is unable to close this channel, so it will release massive amounts of calcium. So whatever calcium in each muscle cell, muscle tissue is being released. So you have an influx of calcium hitting the muscle. The muscle will contract, every muscle, and it's a sustained muscle contraction. Basically, the muscle cell is flooding itself with calcium, and the muscle just contracts and keeps contracting until we stop it. We recognize it first, then we treat it with dantrolene. Okay, let's review malignant hyperthermia. Again, malignant hyperthermia, it's an interaction between the sarcoplasmic reticulum, seen here, calcium, and T-tubules, and of course the ryanodine receptors. The pathophysiology of malignant hyperthermia, it's a mutation or genetic defect in the ryanodine receptors. It's autosomal dominant and diagnosed by the family history or a muscle biopsy. Few hospitals do the muscle biopsy test, but it is doable. When exposed by a triggering agent such as succinylcholine or an halogenated volatile anesthetic, what it does, it impairs the function of the sarcoplasmic reticulum and calcium homeostasis by interfering with the ryanodine receptors. When exposed to a triggering agent, the ryanodine receptors fail to close or they are leaky, which brings us over to the exposure of the triggering agent. Ryanodine 1 receptors is the most common, happens in about 50 to 70% of the patients. Once exposed, calcium is released from the sarcoplasmic reticulum, and the ryanodine receptor fails to close. It just releases a high level of calcium. Exposure to triggering agent results in calcium that is released from the sarcoplasmic reticulum, that is also called the ryanodine leak theory. When that massive amount of calcium is released, it causes sustained muscle contraction or muscle rigidity. As a late sign, under anesthesia, we can see increase in body temperature. An earlier sign would be an increase in carbon dioxide production. Anaerobic metabolism, metabolic acidosis. If we fail to recognize that, the patient can develop rhabdomyolysis, myoglobinuria, and they can also develop acute renal failure. We also have to watch for hyperkalemia, which can cause dysrhythmias. Again, this is a quick review. Here is our stimulus. Calcium comes down the L-type calcium channel, hits the sarcoplasmic reticulum. The SR releases calcium, which is used for muscle contraction, ATP broken down to ADP plus phosphate, and calcium is recycled back through the Circa channel, which is a ATPase base pump, which pumps calcium back into the sarcoplasmic reticulum. Here's the ryanodine leak theory. Here's your normal ryanodine, and here is one that is exposed to a triggering agent because the patient is genetically susceptible and the calcium is released or leaky. I got this slide from the Malignant Hyperthermia Association of the United States. This is a good agency that helps us with patients that are suspected of having malignant hyperthermia. Or the triggering agents are succinylcholine and are halogenated volatile anesthetics such as iso, sevoflurane, desflurane. Non-triggering agents are any other type of IV induction agents such as ketamine, propofol, or anxiolytics such as Versed, opioids. Nitrous is also okay, and all are non-depolarizing neuromuscular blockade. Clinical signs when you suspect a patient that has malignant hypothermia under general anesthesia. You can expect tachycardia to develop and an increase in end-tidal CO2. Despite increasing in the respiratory rate, the end-tidal will continue to increase and tachycardia. If you don't recognize it by then, late signs include increase in temperature, thus malignant hyperthermia, and dark urine from myoglobinuria as a result of rhabdomyolysis. As you can see, anesthetic triggers skeletal muscle contractions, which puts the body in a hypermetabolic state, producing lots of heat, lots of carbon dioxide, lots of hydrogen, using up all the oxygen, resulting in hyperkalemia, tachycardia, myoglobinuria, and can lead to acute renal failure, cardiac arrhythmia or dysrhythmia, and cerebral damage if not treated. Treatment. One of the first treatments you should do besides calling for help is calling the Malignant Hyperthermia Crisis Center or hotline. There is a sticker, a workbook in every anesthetic operating room, probably in the core area. There is a cart with the number in there, 1-800-644-9737. That's a good number to know. Treatment. Of course, the first thing we should do is discontinue the inhalation agent or succinylcholine. Second thing, hyperventilate the patient with 100% oxygen. And what they don't mention in this slide is replace the circuit with charcoal, and I'll show you when we get into the lab. Call for additional help. You're going to need at least 2 to 3 nurses to help prepare the dantrolene. Give dantrolene 2.5 milligrams per kilo IV push and repeats as necessary until the patient starts to cool down or they are less acidotic. Treat the arrhythmias, but do not use calcium channel blockers since this is a problem with calcium. Monitor gases, electrolytes, cool the patient down, grab ice packs, gastric lavage, surface wounds, do anything to cool them down. You can give bicarb as needed also. Let's talk about dantrolene. It's 2.5 milligrams per kilogram with a max dose of 10 milligrams per kilogram. Each vial of dantrolene contains 20 milligrams of dantrolene. You have to reconstitute it with 60 mLs of sterile water, and sterile water being the key. A Foley is mandatory because in the dantrolene is 3,000 milligrams of mannitol. The sodium hydroxide is there just to make the appropriate pH. So let's do some math. If we start our initial dose of dantrolene at 2.5 milligrams per kilogram on a 70 kilo patient, we're going to end up with 175 milligrams, which is equivalent to 9 vials. If we give the patient a max dose of 10 milligrams per kilogram, we end up with 700 milligrams. Divide that by 20 milligrams per vial is 35 vials. The mechanism of action of dantrolene, what it does, it blocks the release of calcium from the sarcoplasmic reticulum. It also decreases the intracellular calcium level and stabilizes the sarcoplasmic reticulum. How are we going to treat a patient that is susceptible to malignant hyperthermia? According to the recommendations from MHouse, flush the anesthesia machine for 10 to 90 minutes. Most hospitals will have in their written policy for 60 minutes. Of course, disconnect the vaporizers from the workstation, use a new circuit, and replace the CO2 absorber. Activated charcoal is great to use. Place that in, and it's effective for 12 hours. If your facility has a vapor-free anesthesia machine, use that one, or an ICU ventilator that has not been exposed to volatile anesthetics. Great job, everybody. See you in lab.